So this is the Fabian HFO from Architronic Wire. The main machine as it is, the ventilator is designed to handle all babies starting from 300 grams of babies up till 30 kgs of pediatric. So you have a dedicated neonatal mode where you can handle babies till 10 kgs and a pediatric mode in the same, because you will be just changing the flow sensor in the circuit.
Okay.
You can go up till 30 kgs. Okay? It's a 4-in-1 ventilator. So what I mean by that is, it can do a high frequency oscillation. It's a true membrane oscillator.
Okay.
It can do all your conventional modes of ventilation. It has non-invasive modes, which was your Cpap, BiPAP, and high flow oxygen therapy.
Yeah. So the high frequency are 4 types. We have frequency jet ventilator, which is not available in Middle East. Frequency oscillator piston, frequency oscillator membrane, and there is something called flow interrupter. Okay, so there are 4 types of high frequency, and I have a very nice publication about comparing jet to oscillator. It's a Cochrane review. I don't know if you know Cochrane.
I've heard, yeah.
Yeah, so I have a Cochrane review about this. Yeah, okay, go ahead.
So this, the machine as such remains the same. There's 2 gas connection, and you just have a flow sensor cable.
No, it's okay.
Yeah, just 2 gases and a power plug and a flow sensor cable, but
Okay.
no plug. Everything is in the front.
Yeah, and you have RS232 outputs.
Yes, you
Okay.
can take it.
Yeah.
The data.
Oh, okay, okay.
You can get them. In front, as I said, like any ventilator, you have the inspiratory side.
Okay.
The fresh gas goes
To the humidifier.
Humidified air goes to the baby. Okay. You have a flow sensor here to
Okay.
measure the tidal volumes of the babies
Okay.
and also the synchroning to pick up
Okay.
the trigger.
Yeah.
Then you have the expiratory limb coming out here.
Okay.
So it's almost the same as that. And then you have your pressure being monitored. So that's why you have the pressure line.
Okay.
Okay. So these 3 will be your conventional modes of ventilation. Whenever you're using non-invasive, just like I showed, and just I was mentioning about these 2, that's when we have this option. So when you're using non-invasive, the only thing is, instead of this, I will take the gas from here.
Okay.
So with this tube, the same one.
Oh, okay.
So instead of this tube,
Yeah,
I will connect it from here. That is the only thing. You can still use the same. I can
But it's not a flow interrupter. It's a continuous flow
it's
Cpap.
a true membrane oscillator. It's not a flow interrupter. Membrane. So switch on the machine. Let me just show you. So just switch on here. This is the home screen. So wherever you are, you press, you come back to the main screen. It'll take you about 5 seconds to set up, to start up. It says just to do the audio test so that you hear the alarms. You say yes, I heard the alarm. Okay. The first thing to do in any ventilator is a flow sensor calibration, because you have to calibrate the flow sensor. Flow sensors could be reusable, or in this case it is single use. The purple one is single use. The yellow one is normally the reusable one. Okay. So to do, it's quite simple. I just occlude
Both sides.
of course with the sterile gloves and
Okay.
thing.
And then you press.
And I just
calibrate.
press flow cal.
Okay.
It says it's done.
Okay.
That's all you need to do. After it, I press this and I can go.
Okay.
Oxygen calibration is automatic, just as I showed you there. So it's a very quick setup. There is no extra steps for you. You just do the flow sensor calibration and you're ready to start.
So you connect back.
They're connected back.
Yeah.
Yeah, so coming to the modes shown on screen, I mentioned this is the main screen, okay? You will notice there are parameters here. Whatever is in blue is what you can set. For example, in CMV, control mandatory ventilation, or IPPV as they call it, we can change the names. There is a mode in the ventilator, so you don't have to be limited to CMV. I can tell the ventilator, I don't want it to be displayed as CMV, I want it to show as IPPV. So that's another benefit. When you have different equipments having the same name, you don't want one ventilator to have IV. We could do that.
Okay.
So it'll be IPPV and SIPPV.
Okay.
So only those parameters pertaining to the mode are shown on screen. So you just touch, again turn and confirm.
Okay.
The parameters in yellow here is what is calculated.
Okay.
For example, based on your IE time and frequency, your expiratory time and IE ratio is calculated. The parameters here shown on screen are what are actually measured from the baby. So it currently shows me with the setting I'm having
So these are the measured, these are the set, these are the calculated
ones. Yes,
okay.
doctor. The measured ones, different doctors may you may want a certain parameters to be displayed. Some of the doctors, maybe if they come on different shift, they may want to have in a different way, so we can have 3 different screens having the same.
Okay.
Some with compliance, with resilience,
Yeah.
or if you want a simple one without.
So you have, can you go back? So you have the, no, back again. So you have the compliance, you have the C20 over C, and you have the minute ventilation max.
Time constant.
Time constant, and this one is expiratory tidal volume, right?
Expiratory tidal volume, yeah.
Okay. And what's the second one? The VTE, BW, over the weight.
Yeah.
Over the weight. And so we don't have the percentage of leak, okay?
Its percentage of leak is, it's over
here.
here, yeah.
But where is the inspiratory tidal volume? You don't see it, right?
Inspiratory tidal volume, is it?
Yeah, because whenever you have leak, then you should have inspiratory and expiratory, and the difference is the leak.
Let me just check. I think it's here.
Okay. It's a VTI.
It's a VTI, no.
No.
Yeah.
Oh, okay. Okay.
Yeah. And then, see, waveforms, currently you can see only one waveform. See, I can see the pressure, or I can see volume, or I can see flow. Because to make provision for everything to see. But in case you would like to see all the 3 waveforms in one volume, I can just go to this waveform screen. So I just press the waveform screen, and all of them are shown in one screen.
Okay.
So you just have to, from the main menu, you just press the waveform and you can see all the waveforms.
Okay. What is the loops?
Loops, there's a button, soft key which shows the loops. I click on this and I can see the loops.
You can see what loops you have. So you have 2 loops.
Yeah.
Okay. You have
volume versus
the volume pressure, and you have the flow volume. Okay. Sounds good. Okay.
I want to come back, you just press the main menu and I'm back.
Okay.
So I spoke about the main menu and the waveforms. Then we have the manual breaths. So this is for the manual breaths as a AMU bagging.
Okay. Looks easier than dragger. Easier than dragger, but still not as easy, as good as I think SLE. Okay. Sorry about that.
No problem. Give me time to finish.
Okay, I will. By my first impression. Okay.
Fine. Okay. Yeah. Okay. So this is the manual breaths.
But I am biased because I worked on SLE, used it for at least 3 years.
True.
And I know it on heart.
Yeah. Then we have the alarms. So if you want to set the alarms, just as I mentioned, I can click on the alarms, and then I can set my alarms. Either I can go for auto set, or manually I can go and change.
Okay.
That's for the alarms. Just by pressing the alarm key.
Okay.
Then I have my sound. If I want any sound,
you can want to silence.
But every sound, alarm is silenced only for 2 minutes.
Okay.
Then I have my other button here. This is a multi-variety. For example, in between I change my flow sensors. I want to do my flow sensor calibration. Okay. Or I change my O2 cell. Or maybe you want pulse oximetry to be monitored.
Okay.
I say after certain process, I thought, okay, let me start monitoring instead of a monitor. On the monitor itself, on the ventilator itself, and then control my closed loop.
Oh, I see.
So that's when I would enable my SpO2. I'll probably do it a little later.
Okay.
Enable it, and then I'll show you how to put it.
Okay.
That could be done.
Okay.
It is optional. So this is also where you can shift between neonatal and pediatric modes.
But you have to change the circuit.
you have to change the circuit, you have to change the flow
The
sensor.
flow sensor.
That's the thing. So this is, and then these remain the same. So every mode you just change. Again, it's the same. So single touch is you're going into a preset mode. You're doing the necessary changes, but it's still running in the other ventilation. And when you decide, you press 2 and you confirm. Okay.
Well, how you add VG?
Yeah. VG is there every mode here. So all you have to do is set what tidal volume you want. For example, now I'm getting about 4.5.
Okay.
I will say I want it to be.
Okay. And this is total, not per kg.
Yeah, no.
This is total.
Total.
Okay.
And I enable it.
Oh, I see.
So when I enable it, it will use my Pmax to.
Okay. Okay. Sounds good. Okay.
If I don't want it, I just remove
Okay.
it.
Okay.
So that's how
Okay.
convenient it is. Yeah.
So what's the difference between Cpap and nasal Cpap?
Yeah. See, in this Cpap, it's not oftenly used. This is still a intubated kind of a Cpap. So it through ET tube, but when you have all the sophisticated, so I don't think you will have a real need. But otherwise, if you want to go with intubated, if you want to just keep a PEEP, then you will go for this and make a Cpap. The next three, NCPAP, DuoPAP, and oxygen therapy, are all non-invasive modes for which you will be using this one.
Okay.
So the only change, what to do is.
Just change this one.
Yeah, I will not do it now. Yeah, probably. Since you have already seen the demonstration on this machine, I would connect this and here, and I would remove this. I will no longer use this. So I'm just using this one, and I'm using the pressure. I will not even use this. And only difference is I have the same circuit. I will put my flow generator between these two.
Okay.
So the same circuit, you can use the conditional ventilation, and then while weaning off, you can connect the generator and change.
I see.
Next coming is a high frequency oscillation. Transition is really simple. You can use the same circuits. As I mentioned, they are firm and they're quite hard, so they don't wobble.
Okay.
Just by single touch button. Again, I have my Pmax, I have my amplitude.
So let's. What is the? This is the mean.
This is the mean, yes.
And so what's the difference between this and this?
Yeah. See, currently this this is in volume guarantee. So we will not be looking, unless we are operating volume guarantee, we will not have this.
Oh, okay.
So the only thing we'll have is the high frequency rate.
Okay.
It's in 10 hertz, which means 10 per second.
Okay.
So if you want, so it's 600.
So this is the amplitude.
Amplitude and
this is the mean.
Mean.
So both we can control them, right?
Both you can control.
So let's go back to mean, like a reasonable mean. There is no P mean like this.
Yeah, it's too.
So let's go to reasonable level in premature baby. Okay.
Double of
So let's go like this. And now?
And now? Confirm.
Where is it? Oh, this one now.
It's absolutely silent. And it's a membrane oscillator, but still it's very.
It will ventilate maybe? Increase the amplitude, let me see.
Yeah.
Make it like 40. Okay, I don't know, I'm not sure. So make it very stiff, not achieving. Make it stiff, make it compliant. Okay. Okay. I need to try it on a baby. Okay.
In any case, whenever you want to. Sorry, let me do this.
I don't want like a volume guarantee of 6 in a high frequency.
Yeah,
it should
you
be
go
like
2.
That's the whole point of giving low tidal volume.
2. Yeah.
Okay.
Yeah, currently I'm having 9, it's too high, yeah.
We'll do simple session about high frequency for the nurses. Very simple one, like 10 minutes.
So now you notice I've selected a volume guarantee of 2.2 and it's taken measures to limit the tidal volume to.
Okay. How frequent you change the circuit?
So this is as per your hospital policy, about 7 days, I think.
Oh, okay.
7 days.
But the manufacturer themselves, we don't give any recommendation. They'll just. So it's,
The
as
change
per-
is just because it lose its elasticity,
No.
or because of infection?
as
why you
per
change
the
it?
Hospital infection control policy.
7.
That's the only reason.
7.
Just because of infection control?
Yes,
Yes.
yes.
Because
Okay.
these, unlike the other circuits, for example, if you were to, I'm just saying, I can see something from comparing. They're quite stiff, so you will not lose power due to that.
Yeah.
But you know better.
Yeah. Looks great.
I can also, in case you need to.
Do you
change-
have adaptive lung, test lung, or just this type of test lung?
No, we have
The adaptive one that I can change.
Create leaks and all
Yeah.
that, right? Yes.
So the adaptive
The
one.
machine actually comes with those. There are
Yeah.
two ones, and where I can make leaks.
Oh, okay. Are you done?
That's main about the machine. If you want me to go into, so this is the almost everything. The additional is the closed loop of oxygenation. Probably I could show it to you.
Uh-huh.
And then one thing very unique about the machine is, for example, if I were to ask you the question, suppose we have a baby. How will you take a clinical decision on saying what is the optimal PEEP to set on the baby, and what parameters would you select? Do you have something objective? For example, your
PEEP, I use something you will never hear about it from anybody else. I use something called dynamic PEEP,
okay,
and I created that term. And dynamic PEEP means depend on the gestation age, postnatal age, and the condition. I select the max and the minimum for the nurses to go up and down, and depending on the monitoring. So, for example, in a term baby, 37 weeks, who has TTN, which is the lung very stiff, I do dynamic, but I start with the minimum, and then I go up if needed. And the reason, because the risk of pneumothorax is high. However, if you have 25 weeks and we have an RDS, usually their chests are very pliable. So I set the dynamic, and I ask the nurse to start from the max, even the first day, because the risk of pneumothorax is low. And then we go down, step down, okay? And then I depend on many things. I depend on the closing point and opening point on the loops,
okay.
and I depend also on C20 over C.
So do you do a manual process where you try different things and then you make?
Now, I look at the monitor. So as I told you, I have like a set.
Okay.
Now, if you look at the study, there is no evidence which is right, which is wrong. But what I do is I do dynamic. So I say, well, for this baby, I'm going between this and this. Then I like, for example, the closing point to be at least double the PEEP. I don't want it to be more than that. If it's more than that, what you're doing is you are inflating and deflating too much. So if you show me like conventional and show me the loop, I will tell you how I select.
Okay.
So I want the closing point to be at least double the PEEP, not be more than double. Okay? So you can freeze it, right?
Yeah, I can freeze.
No, not now. Yeah, you can freeze it now. Now, when you see a loop, I can tell you. So, what is the setting now?
Let me just go.
I have a very good session on the internet about it.
Okay.
Go to the loops again. And once you see a loop, freeze it. Not now. Not now. Did you freeze it? You freeze it already.
Yeah.
Defreeze. Freeze now. Okay. So you can see the PEEP is how much? 5.
5, right.
And you can see the
Depletion.
the deflation point or the opening point
Okay.
is almost like, I don't know, 3. So 1, 2, 3. So the opening point is only 50% of PEEP, and that's a beautiful PEEP.
Okay,
You got
you're
it?
using this one.
Yeah, using the closing point. See, when you increase the
Right,
pressure,
right,
increase the
right,
pressure,
right,
at some
right.
point, you go up.
It goes.
And so that's your opening point, okay? This opening point is very important. For example, I will tell you something. If you have 2 balloons, okay? One is inflated 10 mil, and the other one is inflated 20 mil. And you want each time to inflate it to 30.
Okay.
Which one is easier to inflate?
The
They have 20, because it's only 10 you need to go.
correct.
And that's why you will never have stretching damage. So, and the reason, because the inflation time during PIP is only 50% of the actual, because it's 30 and you already inflated 20, so you'll never have stretching. Okay. However, you need to check something. You need not to compress the heart. So the inferior vena cava by echo is collapsible, and also the pulmonary veins, the flow is okay. So I do echo, and also I do lung ultrasound. So and then I look at the B lines and A lines. I don't know if you know that or not. Then I decide by looking to the loops. So I rarely do gas these days. Now people I know they depend on the blood gas, but I really depend because you know that ventilator had been revolutionized after 2010 because of the loops or graphics.
Right.
That I use it always.
The very reason why I inquired of you is because it's optionally we have a mode called forced oscillation technique. There are some studies published by the Rotterdam University. So what they're trying to do is exactly what you said, but it's only automated in the machine. So what you're trying to do is, you would, for example, doctors would say, I do not know, but I want to search the optimal PEEP for this baby in between 5 and 10.
Okay.
I would select the steps, say 5 and 10, and I would say, give the machine saying, search in 3 steps or 5 steps or 7 steps. What is the optimal PEEP? So so the machine will start at 5. It'll give a few breaths, try to generate the compliance and resilience.
So same what I'm doing manually.
Exactly.
Sorry, I never know that, but I like that. That's the way how I.
Yeah.
So what is FOT for abbreviate
it's
for
called
what?
forced. Zainab, could you just the thing for that? I'll give this to you.
FOT.
Yeah. It's called forced oscillation technique.
Forced oscillation technique.
Yeah.
Okay.
Maybe you can refer to that.
Yeah, I will do that.
So what it does is, so it generates something and then finds what is the lowest PEEP, the best PEEP where it opens up.
Oh, okay.
And it suggests you irrespective of any doctor, everyone will have an objective standard if you at all you go for it. So go for the PEEP.
Yeah. I can tell you most people do that blindly. They don't know, like most people.
But now we have something objective.
Yeah.
Without any. That's something which is unique.
So this is end-tidal CO2, but you should have the.
Yeah, in tidal CO2 there is a module, but you can connect it. Yes.
Is it side or mainstream? Like
micro
it's a micro, but it's in the main circuit or it's a side circuit?
No.
So it is on the side or inside?
No, it will be like an airway adapter.
So inside?
Yes.
Inside the circuit,
yes.
not an outside loop?
No.
Okay.
No.
Oh, okay.
No.
Okay. Anything else you want to tell us?
That's mainly about the.
Yeah. I'm going to stop here. Thank you very much.